Hello again. Here we are with our continue of the topic about acid-base equilibrium. So part 2. If you remember, in the first part we discussed about the basic principles of maintaining the acid-base equilibrium. We discussed about the importance of chemical physiological buffers in maintaining acid-base equilibrium, and we have elucidated mechanisms of respiratory control of pH of extracellular fluids. So now we have to move on to the third huge and large mechanism, and that is renal regulation of acid-base equilibrium. So let's start with the information that the average pH of glomerular filtrate is approximately 7.4. So it is equal to the pH of blood and other body fluids. But the final solution, the final fluid which is excreted, the urine which is excreted, the pH of urine is approximately 6, with the physiological normal range between slightly acidic 4.8 to slightly basic 7.8, even 8.2. So this urine pH decrease is a result of excretion of acids which are formed in those metabolic processes that we have mentioned at the very beginning of this lecture. So our kidneys, they have the ability to excrete all excess acids and simultaneously save basic components in the state of acidosis, and we will discuss about it a little bit later. Or to do the opposite, to excrete excess amount of base and at the same time to save acids in alkalosis. So the final result of those two processes which overlaps is actually that the pH of urine ranges from 4.5 to 8.2. This ability of kidneys to excrete different amounts of acids or bases is really essential for maintaining not only the constant pH, but also the constant concentration of cations or anions. So it's going to be involved in the maintenance of homeostasis of sodium, potassium, and other electrolytes. And we will see that in a couple of minutes. So, renal excretion of acids is achieved by following mechanisms, and we're going to talk about all of those. First, reabsorption of filtered bicarbonate is one very important process occurring at the level of kidneys. Then we have the synthesis of ammonia and excretion of ammonium ions, which are involved in bicarbonate regeneration process. And finally, we have the secretion and buffering of hydrogen ions originating from non-volatile acids. So let's start one by one, and let's focus first on reabsorption of filtered bicarbonate. So why reabsorption? Because our body tends to maintain the constant amount of bicarbonate in the body in the form of bicarbonate buffer. But bicarbonate buffers can be lost from extracellular fluids on one of the ways. So first you have to be aware of the fact that not all bicarbonate ion which is filtered in glomeruli is gonna be reabsorbed. So if the concentration of bicarbonate is increased above the physiological level, certain portion of bicarbonate ions are going to be excreted by kidneys. Oppositely, if there is a lack of bicarbonate ions, then almost total amount of bicarbonate is going to be reabsorbed. There are some other ways. Bicarbonate ions can be used up for buffering hydrogen ions formed during metabolic processes inside cells. reflecting the quantity of extracellular fluids. And finally, a certain amount of bicarbonate ions can be secreted to gastrointestinal tract, and it does not have to be fully and completely reabsorbed. So there is a requirement to do two things: to reabsorb bicarbonate ion efficiently, or to do something to regenerate and replenish used quantities of bicarbonate ions. So the major function of proximal tubules is in maintaining acid-base equilibrium is bicarbonate reabsorption. But we have to face with one problem, and this problem is that luminal cell membrane is relatively impermeable for ions, bicarbonate ions as well. So bicarbonate ions cannot be directly reabsorbed from tubular lumen into tubulocytes, and from tubulocytes to extracellular fluid or blood. So we have to overcome this problem and limitation, and this is achieved by the process in which the quantity of bicarbonate equivalent to the quantity which was filtered can be formed and brought back to extracellular fluid through the sequence of processes occurring in tubular cells. Why is that possible? Because the other membrane, the basolateral membrane of tubulocytes, is permeable for ions and bicarbonate. So on the next slide we will see the figure explaining the exact mechanism, but just before we move on to this one, let me tell you that the key role in this mechanism is the one enzyme, sodium-potassium ATPase, which is located at the basolateral membrane, and what it provides. So it excretes sodium for potassium. So actually it provides a low intracellular concentration of sodium and the negative potential difference at the luminal membrane. So here we are starting with our mechanism. So let's start from number one event. So sodium-potassium ATP pump is active. So sodium is excreted from cells, potassium reabsorbed. So we have the decrease in intracellular sodium concentration, which has to be compensated somehow. This caused the increased efficacy of this antiport system, and this is sodium hydrogen antiport system at the luminal membrane, which actually enables reabsorption of sodium from the lumen and excretion or secretion of hydrogens from proximal tubule cells to tubular lumen. So, hydrogen ions are excreted or secreted to tubular lumen, and now they undergo reaction with bicarbonate ions, and those are bicarbonate ions which we need to reabsorb, but we cannot transport them directly through membrane because this membrane is impermeable, but we can do a couple of tricks. So these secreted hydrogen ions react with bicarbonate ion to be reabsorbed. The reaction is catalyzed by carboanhydrase 4 isoenzyme, and carbonic acid is degraded to carbon dioxide and water. So bicarbonate ion, to be reabsorbed, is transformed to carbon dioxide. We know that carbon dioxide can diffuse freely through membrane, so now this equivalent amount of carbon dioxide diffuses to proximal tubule cell. It undergoes a reaction catalyzed by carboanhydrase second isoenzyme, in which bicarbonate ion is formed and it's transferred first to interstitial fluid and then to systemic circulation in an exchange for chloride ion. So if you take a look here, bicarbonate ion was converted to carbon dioxide absorbed to proximal tubule cells, converted to bicarbonate ion, which is transported to permeable basolateral membrane to blood in an exchange for chloride ions like we had at the level of erythrocytes. What do we have next? As the final step, we have an increase of the concentration of hydrogen ions, which can be secreted again to lumen by hydrogen ATPase, but this system is actually more important at the level of distal tubules and collecting tubules, which we will see in a few moments from now. So in the end, what do we have? We had, for example, 1 millimole of filtered bicarbonate to be reabsorbed. It reacts with the equivalent quantity with 1 millimole of hydrogen ions. 1 millimole of carbon dioxide is produced. 1 millimole of carbon dioxide enters tubular cell. 1 millimole of that carbon dioxide is converted to bicarbonate ion inside the cell, and that 1 millimole of bicarbonate ion is then excreted through basolateral membrane to extracellular fluid. So we have all those equivalent quantities, and thus we achieved the reabsorption, indirect reabsorption of bicarbonate ions. And at the same time, we have exchanged equal quantities of hydrogen and sodium ions. But the reaction of bicarbonate ion formation occurs also in erythrocytes, if you remember my last video presentation. But there is a key difference between events in erythrocytes and event in tubular cells. Because if you remember what I've mentioned before, hydrogen, which is formed in erythrocytes, remains in the body. And hydrogen forms in tubulocytes is secreted to tubule fluid and excreted in urine. So, as long as hydrogen ions are secreted normally, bicarbonate ions form continuously in tubules, and this process is irreversible. So reabsorption of bicarbonate does not cause the concentration changes of neither bicarbonate nor hydrogen ions in the body, because this reabsorption process occurs in cycles. So we're not losing anything, we're just reabsorbing what we already have. And please have that in mind. This is not secretion or regeneration of bicarbonate, despite that they occur following the similar patterns and similar mechanisms. So the replenishment of bicarbonate used up for buffering in extracellular fluids is completed after all bicarbonate is reabsorbed. So while we have and while we can reabsorb bicarbonate, you're not going to activate mechanisms for bicarbonate synthesis and its replenishment. So when tubular fluid enters distal part, we have the situation that most of the bicarbonate is reabsorbed. So no more bicarbonate ions in tubular fluid, but because reabsorption of water also occurred, the phosphate concentration increases. So when you have at the final stage in distal tubules, you have a drop down of bicarbonate buffer, but you have a rise of phosphate buffer, so it overtakes the role of bicarbonate buffer. So from the level of distal tubules on, the function of bicarbonate buffer is going to be completed by phosphate buffer. So which are the factors that affect the rate of bicarbonate formation in tubules? I have listed 3 of them. So stimulatory effect is increased partial pressure concentration of carbon dioxide, decreased concentration of bicarbonate ions, or increased secretion rate of hydrogen ions. Inhibitory, we have the opposite. Decrease in partial pressure of carbon dioxide, increased concentration of bicarbonate ion, or decreased hydrogen secretion rate. And I think that the explanations are rather logical if you get back to put these factors into the previously explained mechanism. So let's move on. So the second thing that we have to explain is regeneration of bicarbonate. So it's completed by proximal tubule epithelial cells, and it's not the same event as regeneration. So what do we have here? I like those simple figures to explain complex things. So we have carbon dioxide, which reaches proximal tubule cell by systemic circulation, and this is the carbon dioxide which originates from our metabolic pathways. So carbon dioxide diffuses freely to proximal tubule cells and undergoes carbon hydrase catalyzed reaction to form carbonic acid, which dissociates to bicarbonate ion and hydrogen ion. So bicarbonate ions are brought back to blood, to systemic circulation, because basolateral membrane is permeable for this ion. But hydrogen ions are secreted by active transport to tubular lumen, like here, in exchange for sodium ions. Sodium ions can be also transported back to blood, and this is very important because upon the bicarbonate regeneration we did more than one thing. So we did actually 3 things. We have regenerated bicarbonate from carbon dioxide and brought it back to blood circulation. We have excreted hydrogen ions, which are result of the metabolic pathways, and we have saved sodium ions, which would be excreted together with non-volatile acids. So this is all about not only regenerating bicarbonate, but doing more things. So regenerating bicarbonate, excreting hydrogen ions, and reabsorbing and saving sodium ions attached to non-volatile acids. The next thing is to see how hydrogen ions are secreted from non-volatile acids, and now we have a different situation because non-volatile acids are not subjected to the mechanism that we have mentioned for volatile carbonic acid. So we have mentioned that non-volatile acids are lactic acid, acetoacetic acid, sulfuric acid, and other acids. So they are excreted exclusively by distal tubule epithelial cells, and they are neutralized and buffered in the form of ammonium ions. And here is the figure representing it. So let me bring you back to what we know very well. So this is the same pattern as we have discussed on the previous slide. So carbon dioxide from metabolism diffuses to distal tubule cells, and it's converted to bicarbonate ion, which is brought back to blood, and hydrogen ions are excreted to tubular filtrate in exchange for sodium ions. But here we have a problem. In tubular filtrate, you're gonna find those non-volatile acids and their anions. So you're going to have chloride ions, you're going to have sulfate ions, you're going to have phosphate ions, you're going to have lactate ions, acetoacetate ions, beta hydroxybutyrate ions, and a bunch of others. So what is going on in the presence of hydrogen ions? So if you remember our chemistry course, hydrogen ions with chloride ions, for example, tend to form very strong hydrochloric acid. Hydrogen ions with the sulfate ions, sulfuric acid, which is also strong inorganic acid. Hydrogen ions plus phosphate ion, phosphoric acid, strong inorganic acid in the first dissociation step, and so on. So if we don't do something to neutralize those hydrogen ions excreted from tubular cells in tubule filtrate, those strong inorganic acids form would destroy kidney cells. So in order to prevent this unwanted effect, we have the following mechanism suggested. So glutamine, an amino acid, neutral amino acid, undergoes reaction catalyzed by enzyme glutaminase, and glutaminase actually removes amino group from the side chain of glutamine, thus releasing glutamate, which undergoes further catabolic processes, and ammonia is released. Now ammonia is secreted to tubule filtrate, reacts with hydrogen ions, forming ammonium ions. Now ammonium ions, in the presence of chlorides, sulfates, phosphates, etc., they tend to form salts, and they do not represent a danger for kidney cells anymore. So this is how we achieve the prevention of kidney cells destruction by excretion of non-volatile acids in tubular filtrate. So let's focus a little bit more on the formation of ammonia and its excretion in the form of ammonium ions. So, some of the authors claim that when bicarbonate buffer is not sufficient to neutralize the excess concentration of hydrogen ions, or when insufficient amount of those bicarbonate ions can be regenerated or reabsorbed, then the system tends to employ the formation and role and activity of ammonia buffer. And if you remember our chemistry course, ammonia buffer consists of ammonia and ammonium ion as a conjugated acid. But I put a question mark here because I think it's pretty dangerous to say that ammonia buffer is actually important physiological buffer, having in mind an enormous toxicity of ammonia. But here, at the level of kidneys, at the level of distal tubules and Henle loop, we have to have certain formation of ammonia and ammonium ions in order to neutralize and prevent the formation of strong acids. So glutamine, we saw it by the action of glutaminase, tends to form glutamate and ammonium ion. Glutamate can undergo deamination process, forming alpha ketoglutarate and ammonium ion as well. So the formation of ammonium ion actually plays an important role in acid-base regulation. And formation of ammonium ion is increased in metabolic acidosis because we have to employ additional buffering system, but bicarbonate buffer to neutralize those excess amounts of hydrogen ions, and also in hypokalemia, and we will see the connection between ammonium ion and potassium ion. So ammonium ion is decreased in hyperkalemia, or when renal mass is decreased, which actually yields to the decreased excretion of acids. So it's synthesized and transported to tubule lumen in exchange for sodium by sodium hydrogen antiporter. So here is the mechanism. Here we are so far. We have glutamine and we have ammonium ions synthesized from glutamine in proximal tubule cells. So approximately 70% of those secreted ammonium ions are actually reabsorbed in ascending lip or Henle loop. This process is completed or driven by this symport system, sodium, potassium, 2-chloride symport system. But in this symport system, potassium is replaced with ammonium ion. So the concentration gradient of ammonium ion, which appears here in ascending limb of Henle loop, stimulates the secretion of ammonium ion by this transporter. This process is completed by degradation of ammonium ion to ammonia and hydrogen ion. So ammonia diffuses to collecting tubule cells and hydrogen ions are secreted to collective tubule cells. This reabsorption and secretion of ammonium ion is regulated by the levels of potassium ions because, as I've mentioned, ammonium ions and potassium ions compete for the same places on this symport system. What about the secretion of hydrogen ions by non-volatile acids like sulfuric, hydrochloric acid, phosphoric acid? They are completely ionized, as you know, as strong acid at urine pH. And they are excreted after the buffering activity with phosphate buffer, if you remember, or with ammonia, as I've previously mentioned. This excretion of non-volatile acids is followed by excretion of cations of potassium, sodium, and ammonium cations. Some other acids, like acetoacetic acid or beta-hydroxybutyric acid, are completely ionized in serum, if you remember the lipid metabolism when we discussed about ketone bodies. But at the pH of urine, they are only partially dissociated. Most of the quantities it's in unionized form, so they do not affect the pH of the urine. The reaction of hydrogen ions originating from obviously inorganic acids with phosphate buffer depends on the quantity of phosphate filtered in glomeruli and of urine pH. Approximately the quantity is 30 millimolar of hydrogen ion in the form of dihydrogen phosphate. Also, this is interesting. An excessive intake of dietary proteins actually increases the phosphate production. It increases its filtration and it decreases its concentration in urine as well. So phosphate excretion in urine is enhanced in acidosis because larger amounts of those phosphate buffers are provided for the reaction with hydrogen ions. Secreted hydrogen ions, we mentioned that they can react with either phosphates or ammonia, so the decrease of pH in urine is going to be insignificant. Further secretion of hydrogen ions and reabsorption of sodium is very important due to certain limitations in pH decrease, which is limited to only 1 pH unit in proximal tubules and in distal tubules 2 pH units more. So let's move on to acid-base equilibrium disorders and illustrate what is going on when these processes and mechanisms are some kind of diminished or disturbed. So kidneys, what we know, they are responsible for maintenance of bicarbonate concentration. But those changes are compensated rather slowly. So it takes from minimum several hours to probably several days to re-establish the equilibrium. On the other side, lungs, they maintain the constant partial pressure of carbon dioxide. And as we have already mentioned, lungs respond relatively quickly to changes in gas pressure. So it will take from several minutes minimum up to 3 to 6 hours to re-establish the equilibrium. So when we're talking about bicarbonates, then we say that it's a metabolic component of pH maintenance. When we are talking about the concentration of carbon dioxide, then we say that it's the respiratory component of pH maintenance. If the pH of blood is the only one changed, then we say and use the term acidemia, so for pH of blood less than 7.36, or alkalemia when pH of blood is higher than 7.44. But if we take into account overall occurring physiological processes, then we are using terms acidosis and alkalosis. So in pathological processes, body's pH can be changed in two directions. In the direction of the increase of hydrogen concentration or decrease in pH, which is marked as acidosis, or decrease of hydrogen ions concentration, thus increase of pH, marked as alkalosis. Further, according to the factor which caused acid-base disbalance, we have respiratory, when we are talking about disturbed lungs function, or metabolic, when we have disturbed kidney function, or some kind of change in the amount of hydrogen ions. So we have four possibilities. Respiratory acidosis, when lungs do not eliminate carbon dioxide properly. So elimination is insufficient and carbon dioxide is retained in the body. So we have metabolic acidosis, when kidney excretion of hydrogen ions is decreased, or the formation of hydrogen ions is highly increased, which overcomes the capacity of chemical buffers to neutralize this production. Then we have respiratory alkalosis, when lungs excessively eliminate carbon dioxide, thus increasing pH, or metabolic alkalosis, when kidneys excessively excrete hydrogen ions. In acidosis, Henderson-Hasselbalch ratio is less than 20, and in alkalosis it's higher than 20. But you have to understand this. Before this ratio is changed, and before pH is changed, our body will take all available actions and employ all available mechanisms to respond to that change and to compensate it by certain compensatory mechanisms. So it's not going to happen that easily. And I'm going to give you two examples. Respiratory acidosis occurs when lungs cannot eliminate sufficient quantities of carbon dioxide. So the concentration of carbon dioxide increases and concentration of carbonic acid also increases. So what do we need to do? So if we increase carbon dioxide, we have to increase bicarbonate somehow. So now kidneys are activated. So they activate those pathways of bicarbonate reabsorption. So they reabsorb more bicarbonate from tubular filtrate, and bringing that back to blood, so to maintain ratio 20:1. So as a result, you're not gonna notice any kind of change in pH because it's compensated. And then we are talking about compensated acidosis. Because, be careful, regardless the constant pH that we have maintained successfully, the absolute concentration of both components are changed. So we have the result is the same, but we have increased CO2, we have increased bicarbonate. So we have increased concentrations of both buffer components, but the result is constant pH. The second example is metabolic acidosis, for example, ketoacidosis, which develops as a result of increased production of hydrogen ions. And this increased production undergoes certain compensatory mechanisms. So something is wrong with kidneys, so lungs are going to get involved, thus increasing the elimination of carbon dioxide from lungs. Or we're going to employ some mechanism to increase the production of bicarbonate ion, the regeneration of bicarbonate, or we're going to somehow increase the concentration of other chemical buffers to compensate this lack of kidney function. So again, the net result of the process is constant pH, it's compensated, but the absolute concentration of components are obviously changed. So let's explain some of the things as an introduction to your pathophysiology course. So metabolic acidosis actually represents the primary lack of bicarbonate ion, and it can develop as a result of either increased formation or decreased excretion of acids, which actually as a consequence has an increased usage of bicarbonate ion. And on the other side, we have an insufficient capacity of tubules to regenerate that bicarbonate used for buffering properties. Or we can have a massive extracellular loss of bicarbonate ion. For example, in diabetic ketoacidosis, in hypoxic lactate acidosis in adults, inherited defects of carbohydrate, fatty acid, amino acid metabolism in children. And let's illustrate some of these that we have already mentioned in some previous chapters. So we have mentioned ketoacidosis when we discussed about the metabolism of ketone bodies, if you remember. And ketoacidosis is a result of an excessive formation of acetoacetate and beta-hydroxybutyrate, excessive formation of ketone bodies from acetyl coenzyme A in diabetic patients and during fasting periods. Lactate acidosis arise from excessive muscle work, and you know that in such a state anaerobic glycolysis predominates, anaerobic metabolism, so the accumulation of lactate or lactic acid tends to yield to the formation of lactate acidosis. Lactate acidosis is also found when Krebs cycle is disturbed due to application of certain medicines like the group of salicylate, or in the shock of the organism. In alcoholism, due to the increased conversion of pyruvate to lactate, also lactate acidosis is one of the consequences. And heavy diarrhea, because there is an excessive, massive extrarenal loss of bicarbonate ions from duodenal juice together with water, and that of course causes lactate acidosis. There is also the group of so-called Reynold tubular acidosis, and there are 3 types, 1, 2, and 4. Actually, those RTAs results are results of inability of Reynold tubules to secrete hydrogen ions or to retain reabsorbed or regenerate bicarbonate ions. So we have type 1, which is distal, type 2 proximal, and type 4 secondary Reynold tubular acidosis. But I'm gonna stop here because these are gonna be topics which you're gonna discuss in details during your pathophysiology course. Speaking of respiratory acidosis, it's the relative lack of base. So the elimination of carbon dioxide is decreased, causing the excess of carbon dioxide in the body and relative lack of bicarbonate ion. So what do we have here? This can be due to the direct depression of breathing center that we have mentioned at the beginning. And this can be a result of, for example, application of certain types of medicines which act inhibitory to central nervous system, like narcotics and barbiturate, opioids, and similar. Then you can have CNS trauma, tumors, degenerative changes, some infections of central nervous system like encephalitis and meningitis, and some comatose conditions like intracranial bleeding. All of those are affecting breathing centers in our brain and spinal cord. The second reason is direct effects on respiratory system due to chronic obstructive pulmonary diseases, lung fibrosis, severe forms of asthma, diseases of upper respiratory tract like laryngospasm, tumors, impaired lung motility like pneumothorax, chest deformities like scoliosis, neurological disorders related to respiratory muscles. So all those diseases and problems which actually affect the rate and depth of the breathing process. Speaking of metabolic alkalosis, that is the primer excess of base, which can arise from, for example, therapeutic application of base salts in excess, for example, sodium citrate in transfusion and application of antacid agents, or due to huge loss of stomach hydrochloric acid because of vomiting or pyloric or intestinal obstruction. Then hypokalemia that we have mentioned before due to hyperaldosteronism or defects of adrenocorticotropic hormones or ACTH, or prolonged application for both diuretics and laxatives. And finally, respiratory alkalosis with the relative excess of bicarbonate. Actually, they arise when there is an enhanced rate and depth of breathing, thus decreasing the concentration of carbon dioxide in the body, increasing the Henderson-Hasselbalch equation, and finally increasing the pH of body fluids. So it can be also accomplished by the stimulation of breathing center, but this time, and it's very typical in the states of arousal or hysteria, anxiety, some febrile states. And I think this is something that you have already faced, or you know someone who faced some of these states. So when you're excited or when you're anxious, you start to do what? To do fast, and you're actually getting rid of too much carbon dioxide. Thus, you're getting your body into the state of alkalosis. So how can you neutralize that, and how can you help yourselves or others to fight this and to reestablish the balance? You know that if you haven't applied that at any time, you at least saw it in films, breathing in that paper bag, if you remember. Because why? If you're breathing excessively into that bag, and it's going to be filled up with carbon dioxide more than it's needed to be eliminated. And then when you breathe again that amount of air, you're gonna get back to your body certain portion of carbon dioxide. So you will try to compensate that excessive loss of carbon dioxide by fast breathing. So, or you're gonna take a sedative, of course. I'm kidding. So, also some other stages like CNS infections, hypoxia due to anemia, hyperthyroidism, pregnancy in the third trimester due to an excess concentration of progesterone, and of course, direct effects on respiratory system in diseases like pneumonia, asthma, pulmonary embolism, congestive heart diseases, and numerous others. So this was just for illustration to see that disturbance of acid-base equilibrium is correlated to a number of medically important states and diseases. So anyway, that was all regarding the story on acid-base equilibrium and those basic principles and basic mechanisms of maintaining the constant pH of extracellular fluids. I hope that I have, at least to a certain point or to a certain level, to make this rather complicated story at least a little bit more understandable and quite easy to figure it out by yourselves and to memorize the bases which you're gonna need for your further and future medical practice. So that was all for this chapter, and until some other chapters and until some other topics, looking forward to hear you again. Bye bye.